It's scary to be a patient. We all know that because we've all been patients, and in fact, we've been patients from the time that we were spanked as naked little children. But it's scarier to be a patient at a new dawn of a new century in which medicine has changed dramatically. Part of the reason that it's scary to be a patient, or for that matter, scary to be a person treating a patient, is that we are, as David Rothman put it, all, most of the time, strangers to one another. I like to give as an example of this the college student. College students visit what's often called the quack shack. There, residents, if there's a medical school, or physicians treat them not just as a number, but as an anonymous person with an individual complaint. This is true also of drive-through medical centers where you got a scratch in the middle of the night. What it is to be a patient as a stranger is an unusual phenomenon. Those of us who saw Doc Hollywood or who just understand the idea of the doctor in terms of that classic model of the white-coated expert who told us what he was going to do, understand how much that change matters. But for the purposes of what we're studying, it matters in a very particular way. Medical ethics has been driven, at least since the 1980s, by a kind of fundamental orientation toward self-governance or autonomy. That is, we have thought of ourselves, because we're mostly working with strangers, as being a little bit at risk. And the focus for those of us who are patients, whether we are, while we're working, doctors or lawyers or the most knowledgeable scientists about medicine, we've thought of ourselves as being vulnerable and worried about being vulnerable. Because while when we lease a car, there's a contract, and when we buy a house, there's a contract. When you come in after an automobile accident, there's no contract, or at least not one that you'll be signing. The vulnerability that comes from that has probably best been captured by the bioethicist who first practiced in clinical ethics, Richard Zaner. Richard Zaner referred to something called ethics in the clinical encounter, and when he talked about it in terms of relationships, or more specifically, what he called the therapeutic dyad. By that, Zaner meant essentially that you could draw out a kind of diagram within which we all exist once we become sick. Eric Cassell had said, the best way to understand a sick person in a hospital is to do a kind of, what he called an anecdotal study. He took a tall flask and a tall beaker and a small flask and poured 100 milliliters of red liquid into each. He walked this tall beaker and small flask from patient to patient in what is now Cornell Weill Hospital, and he asked people who ranged from professors to people who had literally been admitted right off the street where they didn't have a home, which one of these two vessels containing 100 milliliters of liquid has the most liquid in it. And the answer that patients gave almost invariably was that the tall beaker, which appeared to have more liquid on its face, had the most liquid. It didn't matter for a cardiologist who said that it was the tall one that had the most liquid. Cassell said we're vulnerable because our perceptions of ourselves change when we become ill. We start to worry, but more than that, we think of the world around us in terms of, well, let's just think about those surroundings. The clinical surroundings of an intensive care unit, or even of a maternity ward, are very different from almost any other encounter we have with a professional. Your accountant, if he were to lead you into a room where there were bright spotlights and machines that go ping, would terrify you and you'd run screaming. There isn't an attorney who isn't scary already, but were you to come into an attorney's office and they were to ask you to undress, you'd immediately say, no thanks, and walk right out the door. And yet in clinical encounters, you are constantly confronted by people who wake you up, who poke you, who prod you, who remove liquids from you, who ask you to do some of the most intimate things in the world. So what is this relationship within which we're vulnerable that scared us so much that in the 1980s and from there forward, we began to focus so much on protecting ourselves, and more particularly on the theoretical concept you'll hear so much about in this class, autonomy? Well, the answer to that is pretty straightforward. The difference between the two sides of people involved is dramatic, but each one is social in nature. On the patient side, we are ourselves, as it was put in an 80s pop song appropriately, but we're also part of circles that, as they encircle us, in part define us. We are part of, for example, families, and laws in various states recognize that. If we can't make our own decisions, then families are often designated by us or by the law as surrogates for us. But we are also literally our families, in that our parents taught us not to cross the street when there were cars. Most people have the same religious affiliation as their families, and families can surround us, particularly at times when we're ill, with their own values. And in our own interactions with family, the tensions can, data shows, really play an enormous difference in who we become and how we think about our lives. Beyond that, though, we're also part of a community, and that community has a number of different parts. Some of it's just straight up financial. If my insurance plan doesn't provide for me to have a certain kind of drug, or has a restriction against transplants or experimental therapy, or for that matter, enrollment in clinical trials, that constricts the options that I have. So as a person who is a patient, I am rather restricted. I'm not listed for a liver transplant. That means I'm not a person who's a candidate to have a therapy that might extend my life. I'm not high up on the list for a heart transplant. You deal with me in a different way. And beyond the financial, we are Little League coaches, we are fathers, we are people in the community who play different kinds of roles that all the way back to the Seattle Dialysis Committee that faculty member Myra Christopher discussed, have played a role in social decision making. People ask, do you drink? They ask, what kind of work do you do? The minister who comes into a hospital in which he works is in a very different position, as is the doctor who works there. On the other side of things, on the other side of the dyad, is, well, the physician, who is part also of an enormous community. Physicians are not only themselves, but also the unit in which they work, which is comprised of nurses and others. Often on rounds, so-called social discussion takes place, and people talk about the patient's history in terms of the medical dimensions, but also about what it means for the psychosocial dimensions of the case to play a role. So the physician becomes part of a description about the patient and brings that understanding to the patient as they come in. There are also staff or faculty members in an academic institution or members of a practice group in which there are, well, money considerations. There are now considerations with government and how it plays a role in healthcare. There are considerations that relate to whether a patient is just a patient or also a research subject, and considerations about what it means for a different hospital from another hospital to treat people in a particular way. Some hospitals have emergency rooms or trauma centers and of higher and lower levels. Other institutions don't have anything like that and don't treat for particular kinds of conditions. So that means that coming into the dyad, you have two different people, but more than that, it's almost as though in that room there is an invisible crowd on each side, the patient and the physician. And that may sometimes make them combatants. But the more important fact, Zainer reminds us, is that the hospital, the nurses, the technology side on the one piece, and those of us who are members of the intimate group and the larger group, whether it's the church, the employer, the insurance company, on the patient side, make up who we are when we are vulnerable, naked, giving our fluids, taking parts from other people, and otherwise being vulnerable in the context of a hospital. That dyad is how we bring our autobiography to physicians when we are patients. And in a way, it illustrates why illness and disease are so different. It's an idea, a concept that seems sort of obvious at the outset. I mean, obviously, illness and disease are different, just as suffering and pain are different. But understanding this in terms of the kinds of relationships that take place in the hospital is a key first step to seeing the complexity that's present in the relationship between those who are engaged in clinical ethics consultation and those who are engaged in the practice of medicine and those who are actually requesting our services as ethics consultants, members of hospital ethics committees, and otherwise.